So welcome back to the panel discussion we are now going to have on NF1. And I'm also happy to welcome Daniel Munoz. He's a psychologist and working mainly in quality of life and body image of adult NF1 patients. And I would like to address the first question to you. We just heard a lot about medical aspects of NF1 and genetic testing, but how does the diagnosis of NF1 affect the patient, their families? Do they usually go through different phases, and what type of psychological support can be useful in that time?
Okay, so how do impact on the patients? I think it mostly impacts on everything because it is a major change in event life. So what aspects? It spreads alongside different fields and different aspects. Especially in family, we see that there's a lot of sensation of guilt. Mostly if they have already the condition, the NF1 condition, because they tend to feel that like they pass this through their childs, and so there's like a lot of feeling of guilty and frustration. And that could lead to major psychological problems, like, for instance, anxiety or depression, and also the children and the people that are suffering it. What are the stages, the phases? They are not that different from like a normal grieving process, because they are individuals and they tend to feel the same like we all feel. It's not really different from what is grieving. They went through different stages. Of course, the frustration and the guilt is it's something that it's following them alongside their journey, but not really different from what is a grieving process. And I think that we should address it as an individuals, and we should look at the differences and to look at what they may have as an individuals, not more like as a condition, as a genetic condition.
Thank you so much. Eric, I would like to address the next question to you. Children with NF1 often have neurocognitive issues like learning difficulties, visual spatial perception issues, ADHD, or even autism spectrum disorder. Can you please explain why children with NF1 often have these issues and what can be done to support them, especially during their school career?
Yes, this is a very interesting and also important question, because this morning we have been talking on RAS and neurofibromine, but in the process of tumor formation. But we also know that RAS and neurofibromine are important for learning, because during learning we have to reinforce certain connections between brain cells. We also have to weaken certain connections between brain cells. But when neurofibromine is low or absent, we know that the weakening of connections becomes more important, in the sense that it is easier to weaken a connection than to strengthen a connection. So it shifts towards weakening, meaning that it is harder to learn something and that it takes more effort and more cycles of learning, and that it is also easily forgotten again, because you have to maintain this process. Otherwise, it shifts again towards the process of weakening connections. We know that it is very variable from one person to another person with NF1, and we don't know exactly why this is the case, but we have to take into account that every child or adolescent or even adult with NF1 might have a learning problem, but they do not share the same problems. It can be very variable, and it might not only concern typical learning at school, but also learning how you socially interact, or learning how you take care of your temperament and your activities and concentration. So I think that every child needs an individual approach, making sure where the different potential problems are situated, and needs a specific management program by an experienced psychologist or special educator to make sure that their specific needs are met and it's not a one program fits all, but it has to be individualized.
Thank you so much. Very important to not forget about the individualized approach here. Ignacio, during your talk, you described the importance of a transition program for people living with NF1. What are the most important 3 things that every young adult needs to know about their condition, about their health?
Okay. 3, but I will say they need to know what is the condition, what is NF1, why it disappears, what kind of manifestations they can be, to know these, I will see, signs of alert. This is one. The second one, he has to know all the treatment possibilities that they can have, and if they are taking medications, why they are taking. And the third one is to know about the possibility of passing the disease to their offspring. It means they have to know how to realize how to be prepared for the family planning. And in that aspect, we have to deal with all the sexuality and everything. And it's a different and a special moment. And we have to be very clear about the possibilities and the difficulties having that. But I would like to say one thing. According with Eric's explanation, one of our experience here in Spain, when I talked with our coordinator of the Reference Center for Child, is the number of patients with learning disabilities. The proportion of patients in the childhood with learning disability is completely different from the ones that we have. This means that we lost that kind of patients in the transition process. And then we have to be very careful about these patients that have learning disability or social problems, because they used to not go to the adult. And again, we have to personalize how to deal with these patients. That's something very important.
Thank you, Ignacio. Daniel, coming back to you, what are the main psychosocial challenges that adults face, adults with NF1? Do these challenges differ in any way from children?
Okay, so the main problems that an adult of NF1 tend to have are mostly related with their condition and mostly related with their physique, chronically. For instance, they tend to have a lot of body image impairments. They tend to feel like their body is not normal to what social it is, to what we consider social. And they tend to have problems socializing with it. Like they tend to have a lot of social problems. They tend to have major problems when seeking social support. So they tend to feel isolated. They tend to feel alone. They tend to have frustration because of it, and a lot of emotional problems, like I said, depression and anxiety. And that is really not different from children, but it is in the way that it is expressed, because it's different. Like children really need a lot of social support. Adults may have more strategies to deal with it without having this social support, but still is needed in both of these stages of life.
And maybe a question to the whole panel, like, how should optimal NF1 care be organized? And what is currently holding us back in the different European healthcare systems to provide this sort of specialized care? It's a very big question.
Yeah, I will start. I think as you said, every country has its specific healthcare system. So within every country, all the problems should be identified. They are different from one place to another. But I think an important thing is if patient organizations go to, let's say, the healthcare system managers or the government to say that they need a specific approach and that also funding is provided for a specific approach, like multidisciplinary meetings, multidisciplinary consultations, discussions, and so on, that they really need this if this is not available. Because it's sometimes very difficult to organize this in the absence of any funding for it from the healthcare system. So this is something that that could be done by the patient organizations. And then secondly, as we talked over the coffee, it's important to organize a transition from childhood to adulthood. And also there, I think there is an opportunity for the patient organizations to make their own adolescent and young adult groups because they are interested in different things than children and also in different things than all the adults. So if one can organize something for them that they stay together as a group during a couple of years, where it is also emphasized that they need further follow-up later on, even if they don't have any problem at all. We might, and then they have very good relationships also with social networks and so on, with all the people that they know in this group, then they can evolve within this group into the adult group. I think that would be very important also for every country, and this is something that could be done by the patient organizations. You don't need a government for this, you don't need reimbursement for specific services, but you can do that on your own.
I'm completely agree with Eric. I think that patient organization is the one that can help us to transform the health system. The patient associations has to bring their needs to the policymakers and convince them what is needed for the patients. He was saying that every country has a different health system. Here in Spain, we have 17 small communities with 17 different health systems. And then we have to focus in the real problems. One of them is the adult way that we offer healthcare. The multidisciplinary approach is very common in the childhood, not in the adulthood. Only in the, I will say, oncology area is multidisciplinary. Then we have to transform it. Patients like NF1 that can have a lot of different manifestations need a multidisciplinary approach. Patient cannot afford to go every single week to visit a different specialist. We have to transform the health system in order to be able to see the patient one day. And if we believe that the patient is the center of the health, all doctors should be around the patient in the same day. We have to transform the health system. And patient association needs to go to the policymaker and say, hey, the way that you used to offer health assistance in the adulthood is not the correct way for our community.
Thank you. So a clear task for us patient organizations, and I think it must be a shared approach. If clinicians, experts, and patient organizations together demand the same things, the same improvement, the needed improvements for the community, then we can be successful. I also want to invite the audience here in the room to ask questions. If you have any questions, please raise your hand and I can bring the microphone to you. Rina.
Thank you very much. I wanted to ask if there are any other factors who help the plexiform neurofibromas to alterate to MPNST tumors, such as the beginning of a habit, such as smoking or a sudden injury.
This is a very interesting question. At this moment, we know that smoking is very bad, but it does not affect the transformation of the malignant to a malignant plexiform neurofibroma. But we know that smoking, for instance, for adults with NF1 is very bad because it affects their lungs much more than the lungs of a person without NF1. And I have seen young adults like 40 years old who had already very severe damage to their lungs, and this is known in the literature, but there are only very few reports on the fact that smoking is so bad for individuals with NF1. Luckily, it does not affect the transition of a plexiform neurofibroma to a malignancy, and at this moment we know what happens when they transform, but we don't know why they transform, and probably some random things that just happen at a certain moment in the genes of a cell are important in determining this. So it is very difficult to predict. That's the problem. And also we know that diet doesn't have an effect on it. And we also know that if someone has an atypical neurofibroma that is already slightly transformed, but not completely into a malignancy, we know that treatment with selumetinib or other MEK inhibitors will not block it from becoming malignant. And then we know that surgery is very important at that moment, because at that moment, if you do surgery, you don't have to take away, let's say, the nerve and everything that surrounds the nerve. But if you wait until the tumor is malignant, you have to cut away the tumor and some normal tissue in the environment, so surrounding the malignant tumor, to make sure that you have everything. And then, of course, this is very, very damaging for the patient, because then the nerve is completely gone and the person will have severe paralysis. And even you cannot guarantee that everything is gone. But if you can detect it at the level of the atypical neurofibroma, and if possible, you can resect it, then you have prevented a malignancy from happening. And this is exactly what we have done in a study where we published the follow-up of more than 270 individuals that were followed closely with once a whole body MRI and then targeted MRIs if suspected tumors were available. And we could prove that after some follow-up that there were less malignancies in this group than expected to happen based on the general numbers. So their surgery becomes very important, and especially having a very skilled surgeon that can remove the tumor without too much damage of the nerve.
Yes, if I can say something, that I think that Eric's paper that has been released is very important. We have no idea right now how this transformation process starts. We are looking for biomarkers. But what we have to do right now is to go in and try to find the patient that is starting transformation. And for that, Eric's papers group is very, very important. We have to go ahead the transformation.
Before there is any symptom.
Yes.
So if you wait until there are symptoms, then it might be too late. That's why also in the ERN Genturis guidelines, it is said that if possible in your healthcare system, you might consider having a whole body MRI once at transition from childhood to adulthood, because in that period, you will already see those neurofibromas that have a tendency to transform, let's say, slowly to atypical and then slowly to malignancies. And in many of these tumors, it takes years this transformation process. And some never transform into a malignancy, but stay at the level of atypical neurofibroma. So if we can remove as many as possible right now, we can improve the prognosis. And in the future, what we would like is to really remove only those that will further transform. But now we cannot tell the difference between one that will stay stable over time and another tumor that will transform in the near future. Once we can tell the difference between the two, of course, we only have to remove those that will transform in the near future.
Time is flying by so fast because I would love to sit here for another hour and ask you 100 more questions, but we have a very